morning, good afternoon, good evening, wherever you are. My name is Emmanuel Nsutebu, infectious disease physician and chief for infectious diseases at Sheikh Shagbut Medical City in Abu Dhabi, UAE. It's a pleasure to chair this session, and you're all very welcome. This is a very topical session, the fourth session of the World Sepsis Congress Spotlight on sepsis, Ebola, and COVID-19, linking sepsis with emerging infections. So clearly very topical with the COVID-19 pandemic. We've got some excellent speakers who I'm sure are going to educate, engage, and perhaps even entertain you. And so we look forward to the great presentations which we're going to have in this session. Each speaker is going to have 10 minutes to present, and then there'll be 3 minutes of questions and answers. So I would urge you to use the chat box to pose your questions, and I will choose some questions to ask the speakers. Without much ado, I'd like to present our first speaker, who's going to give us a keynote presentation on the World Health Organization clinical response to sepsis, COVID-19, and sepsis. Our first speaker is Janet Diaz, who I know very well as she is a member of the advisory board of the African Sepsis Alliance, which I chair. She is an accomplished specialist in pulmonary and critical care medicine with expertise in clinical medicine and global health. Since 2018, Janet has worked as the lead for the clinical unit that is responsible for readiness and response to emerging infectious diseases, including COVID-19 and Ebola and other emergencies. And she's part of the WHO emergency, which is part of the WHO emergency program. So without much ado, I'll pass the floor to Janet to give the keynote presentation. Thank you.
Thank you so much, Emmanuel. I hope you can hear me. So I will proceed. Thank you for the introduction, and we'll get to it. It is a privilege to be here, and I welcome all the guests and my fellow speakers to this very important event, and I hope everyone has been enjoying so far and continues to enjoy and learn from each other. I have 3 objectives. 1 is to discuss the recognition of sepsis and emerging infectious diseases. 2 is to remind you that we must do the basics well, and that includes infection prevention and control and supportive care. And 3, that research and innovation during outbreaks is really a must. Just to give you the one slide of which has been the hot topic of this whole meeting is sepsis. So yeah, the sepsis in emerging infectious diseases. And just to remind you of the definition that was published in 2016 about sepsis 3, life-threatening organ dysfunction caused by dysregulated host response to infection. So the body's response to an infection injures its own tissues and organs, and this is straight from this article. Now let's jump to Ebola disease. I want everyone to be aware there is still an ongoing Ebola outbreak. This most recent outbreak started on the 1st of June in Bandaka, which is in the western part of DRC, a very remote area of DRC. And to date, we have 113 confirmed cases and 48 deaths. On the map, you will see Bandaka and also see the eastern part of Congo DRC, which had a prolonged outbreak from 2018 until just recently in June of 2020, where there was a total of 3,463 cases, 2,280 deaths. And then, of course, highlighting at the bottom, the West African Ebola outbreak, which many of you are aware of. But what do we know now about the clinical presentation of Ebola? These are 2 nice review slides that I found in the literature, really looking at the early disease where you can see some non-specific features of fever, malaise, lethargy, and then within 3 or 10 days starting to see the GI phase, which is what classically people consider diarrhea, vomiting, and at that point patients unable to take enough oral fluids in order to compensate for their progressive dehydration. And then the complicated phase, which is about a week or more in, where patients then do develop the overt hemorrhagic signs, shock, respiratory failure, multi-organ failure, neurological failure, renal failure, and eventually death. You can see some of the laboratory abnormalities listed in the table on the right, and mortality ranging overall between 40 and 70%, varying by outbreak in countries, and even reported lower mortality reported in West Africa and high-income countries at that time. The next series of slides, I won't talk too much because there's too much detail, but really to highlight, again, a nice review article on the pathophysiology of inflammation leading to organ failure. So the activation of B cells, inflammatory cells, the progression of injury to the liver and activation of macrophages, more inflammatory response, and finally leading to the injury of endothelial cells, which will then lead to, of course, organ failure. I'm going to step on to sepsis and COVID. So as of the 8th of September, we have over 200 million confirmed cases of COVID-19 that have been reported to the WHO, and nearly 900 deaths. To the right, you can see slides that we produce on a regular basis, just looking at the impact of cases on the top per million population, the darkest colors with the most dense number of cases, and on the bottom, the purple showing the deaths per million cases, those in the darkest purple hue, also with the highest number of cases. And you can start to see where the burden of disease is at this moment in time. What do we know about the clinical presentation? Of course, patients may present, the majority will present with mild disease, and that's a range of symptoms listed here. But we do know that a subset of patients do present with severe and critical COVID, and the syndrome that is described in the literature, I'm just summarizing here, includes acute respiratory distress, acute kidney injury, coagulopathy, altered mental status, progressive acute respiratory distress syndrome, and in some cases, cardiogenic instability shock, leading to death. Mortality is hard to elucidate overall because the CFR varies widely based on the testing strategy, as well as the mortality rates in hospitals. We are understanding the risk factors for disease, as many of you already know: older age, male gender, underlying non-communicable diseases, smoking, obesity, as well as some biomarkers. And what do we know about the pathophysiology? And so these are, just a recent review. Again, these are things that are plausible pathophysiology. That's things we still need to learn about the disease. And so here we can see, of course, activation, infection of the alveolar epithelial cells, activation of macrophages, and then injury to endothelial cells through the inflammatory cascades and activation of the coagulation cascade. So what does that mean now? So I was asked, is sepsis, COVID-19, Ebola? I think I've shown you that, severe COVID, severe Ebola disease is sepsis. It looks like sepsis clinically, and you can see from the inflammatory dysregulation that is likely the pathway to organ failure and death. So what can we do? So we do the basics well, and here I want to make a push for IPC and supportive care. What we face during outbreaks are many complicated issues, as you know, especially during this pandemic. The first thing we worry is healthcare worker infections, because at the beginning of an outbreak, the IPC appropriate measures may not be implemented, and so healthcare workers become infected and may die. We are fearful of the lack of effective antiviral agents. If it's a new disease, we don't know what to give. We know that there are supportive care interventions, however, that we use in sepsis and other severe infections, but it's indirectly then applied to either Ebola or COVID. And then resource scarcity, staff, supplies, structure, symptoms. The system may not be ready to take the increased flood of patients from the outbreak in whatever resource setting you are in, and that will amplify disease spread, mortality, and distrust in the community. So it is imperative to do the basics well. Screen, isolate, implement IPC. That's the first step. So during the outbreak, this is crucially important. With someone with an emergent infectious disease may present with sepsis, you must recognize the patient early and start IPC. At the first point of contact, notify your public health officials, but do not delay triage and clinical assessment. So here, those two things have to be done simultaneously to keep the health worker safe and to give the patient the treatment they need. For this outbreak, we developed the COVID care pathway. And again, this was just really to highlight the importance of screening so that patients can enter into a pathway where the appropriate infection prevention control measures are put into place, but not to delay the acuity-based triage that needs to happen to find those patients that need emergency care, the clinical assessment, and then of course, the decisions of where to admit the patients. The second step is to provide optimized supportive care. And in Ebola, this is what, we focused actually. I spent a very long time in DRC during when the Ebola outbreak started in the eastern part of DRC. I won't speak too much because my good colleague, Richard Kojan, will speak about this a little bit later. But what did we learn about the management for supportive care? And these are evidence-based guidelines that you can find, recognize dehydration and sepsis, and treat with fluids. So that's number one, monitor and correct abnormal electrolytes and hypoglycemia, give transfusions for severe anemia, give oxygen if respiratory distress, and of course, rehabilitation, nutrition, and psychosocial care. And this, we adapted the evidence-based guidelines and developed an optimized supportive care protocol for Ebola virus disease, which was used in the DRC, this most recent outbreaks. How about optimized supportive care for COVID-19? Again, I think one of our colleagues will discuss this a little bit more. But we had to start with something. So we published our earliest guideline actually in February, and this is the most recent published in May. But again, the same basics: screen, triage, clinical assessment, monitor for oxygen, give oxygen if in distress, recognize sepsis, treat appropriately with fluids, monitor and treat complications as we've seen, thrombosis, neurological dysfunctions, monitor for ARDS, and provide safe, appropriate respiratory support, which may include non-invasive high-flow IMV, bundled with safe sedation and liberation protocols, and of course, rehab, nutrition, and psychosocial care. And you can see 3 important documents that are available on our website on the supportive care and the safe care of patients with COVID. But what else did we have to deal with for COVID-19 was the supply structure and staff. So the WHO set up a global supply chain system to ensure access to life-saving biomedical equipment and scale-up of oxygen. And the focus here was, of course, the concern of countries that do not have strong oxygen systems, as we knew that even in some of the most resource settings, that the oxygen systems were strained in some of the older hospitals in various cities. So here are the tools that we have about scaling up, understanding your biomedical equipment at facility level so you can scale up, how to make your center or repurpose your hospital to make it safe, so a SARI treatment center manual. And then just to highlight that WHO, along with its consortium of many partners and with WFP, delivering over 13,000 concentrators to the countries that you see in dark blue. Lastly, research and innovation during outbreaks is a must, and this should happen in any setting. In Ebola outbreak in DRC, which is in the east part, an active conflict zone for 20 years, we were able to conduct with multiple partners under the global collaboration of the National Institute of Biomedical Research, the INRB from the DRC, under Professor Jean-Jacques Muyembe's leadership, as well hosted by the NIH and with partners MSF, IMC, ALIMA, and WHO. This trial, the Pamoja Tulinda Maisha trial, which is in Swahili, which means Together Saves Lives. That enrolled 681 patients into a randomized trial looking at 28-day mortality. And in that trial found that MAB114 and Regeneron EB3, which are both monoclonal antibodies, reduced mortality when compared to ZMapp, which was the standard of care, significantly. And that remdesivir in this patient cohort had no difference compared to ZMapp. Also noted in that study was that fewer days of onset of symptoms, lower viral load, and lower creatinine and AST were associated with improved survival. And this was published late last year in the New England Journal. But therapeutics aren't enough. In DRC, we had to find and develop safe treatment units, but treatment units that enabled the care of optimized supportive care. And this was done through innovation. So the last outbreak in 2018 through 2020 in the eastern part of Congo saw the development of new Ebola treatment unit designs. And on the top is what we will hear in more detail by Dr. Kojan, the cube that was used by the ALIMA group. And then integration of monitoring devices such as vital sign monitors, ultrasound, point of care testing, all allowing for individualized supportive care interventions. How about science and innovation in COVID-19? We know this is an incredibly large field. The WHO convened in March, published this in March 2020, but convened the meeting, I think, in late February, a coordinated call for global research for a novel coronavirus. 9 work streams were developed at that time to cover all aspects of research, including social sciences, ethics, clinical, etc. And the sepsis-related interventions, I think, are falling under multiple streams. One is the stream that I lead, which is a clinical characterization and management working group. Others in the candidate therapeutics and vaccine group, of which our colleague Marco will give us more details about. And of course, in IPC and healthcare worker protection. And so priorities were set at that time, of which all groups have been steadily working towards over the past 7 months, including the solidarity trials on therapeutics and vaccines, prospective meta-analysis on other interventional studies that are being done, working on oxygen scale-up with operational research, respiratory support, and reducing healthcare worker infections. Finally, through this work, we do finally have one evidence-based strong recommendation for treatment in COVID-19, and this was published last week, which was a strong recommendation for the use of steroids for severe and critical COVID-19. And that was based on the large recovery trial, in addition to 6 other trials that were pulled together into a prospective meta-analysis that was published last week at JAMA, showing an absolute risk reduction of 8.7% in critically ill patients. Other interventions we're exploring now to see if there's a possibility to bring studies together, because there are multiple ongoing smaller studies, which will make it difficult to understand the results, including for anticoagulation and plasma therapy. A big priority right now is to continue on the operational research in low middle income countries or in resource limited settings to get a better sense of oxygen at facility level, to do an observational cohort study to understand patient oxygen consumption in order to prepare and get the places ready. And then test interventions for early respiratory support and how that would impact outcomes, especially early respiratory support that before the need for invasive mechanical ventilation. And then look at innovative respiratory devices that may be applicable to certain settings and at lower cost. So in conclusion, sepsis is a presentation of emerging infectious diseases such as Ebola and COVID-19 and needs to be detected promptly. Doing the basics well is necessary to reduce mortality. And the basics well is to screen, isolate, IPC, triage, clinical assessment, and supportive care interventions. And when available, give the effective and safe therapeutic when we know when that exists. And of course, monitor and evaluate your processes and outcomes in a quality manner. And finally, research and innovation is essential to improve our understanding of these diseases, from clinical characterization to structural design and ventilation in IPC to therapeutics and vaccines. But large-scale coordinated trials are necessary, and global coordination and collaboration is a must to get to the answers faster. So thank you. And I thank my big teams that work on COVID-19 and the teams that worked on Ebola with us in the field.
Thank you, Janet, for that excellent presentation and a lot of take-home messages there. In the interest of time, I'm just going to ask you a few questions, if you don't mind. The first is about the reasons for the prolonged outbreak of Ebola in the DRC and role also of vaccination in controlling the outbreak in DRC.
Thanks, Emmanuel, for those excellent questions. So the long duration of the outbreak in DRC, I think, revolves a lot about the context in which we were working in. The context of North Kivu is a conflict zone with a lot of instability, which meant that there was episodes of violence, episodes of insecurity that would intermittently stop operations. And I think if you would remember, even at one point that Ebola treatment units, 2 of them were burned down in the middle of the outbreak in Butembo and required us to build back up. Despite that, though, we continued with setting up facilities, treating patients, doing vaccinations, doing contact tracings, but each time there was an event, things would slow down. And I think that was mostly the protracted. And of course, I didn't put a slide in or even a point about vaccines, but that was definitely an intervention that was used to control the outbreak, the contact of contact, strategic approach to vaccinations.
Great, thank you, Jen. And since this is just such a topical presentation you've given, just a question about COVID-19 and Africa. It's been a surprise in terms of the unexpectedly apparent lower number of patients with COVID-19 in Africa, lower than most people expected, including mortality and need for critical care. Any thoughts from you, also working the WHO, about why that may be the case?
I think we still need more information to understand better the clinical characterization in Africa. And we are working on that with many partners right now, including Dr. Kojan, who will soon speak and may have his reflections on this important question. There is the possibility of the age of people in Africa being younger than the age that we're seeing, perhaps the mix of comorbidities, those things that we do know are risk factors. At the same time, there is also concern that we are not testing as much. So whatever the denominator may be bigger, but when you talk about the severely ill, the ones that would end up in hospital, the ones that would die in hospital, are we capturing all those and accurately with testing? I think there is still a question about that, but it does appear that there is less in Africa, and for that reason, we need to understand this both from the immunological side, if that is true, what is the pathophysiology, and what are the risk factors that are happening in that part of the world.
Great, thank you, Janet. And in the interest of time, I think we'll move on to the next speaker. So thank you very much for your presentation and taking those questions.
Thank you.
Thank you. So our next presentation is going to be on managing sepsis in COVID-19 patients, special considerations. And I have the pleasure of presenting our next speaker, who is somebody I know well because she is a colleague from Abu Dhabi, UAE. Dr. Hala Abuzeid is a consultant in critical care medicine and chair of critical care at the Tawam Hospital in Alain. Hala was also chair of the Critical Care Council that led the coordination of the critical care response to COVID-19 in Abu Dhabi, which is part of SAHA, the SAHA government health system. And she also ran the largest intensive care unit that looked after COVID-19 patients in Abu Dhabi. So clearly has an immense amount of experience looking after patients with COVID-19 as well as sepsis. So very well placed to give this presentation.
He's presenting.
And I'll then pass the floor to Hala to present.
Good morning, good afternoon, good evening, and thank you very much, Emmanuel, for this generous invite and introduction. And very happy to be with you to talk about an important topic, especially when it comes to critical care support during the pandemic. And as our honorable previous speaker mentioned, the definition of sepsis as a life-threatening organ dysfunction caused by dysregulated host response to infection is almost the same definition that COVID-19 carries as well in the context of ICU. And basically, the severe COVID-19 is also characterized by multi-organ failure that includes all the dimensions of severe sepsis, including hypertension and shock and respiratory failure, kidney failure, coagulation abnormality, and so forth. So basically, we're talking about a disease that mimicked sepsis, and we had so little that we knew about at the beginning of the pandemic, and that faced us with a lot of challenges. I don't have any disclosures at the moment, and I would dive into the United Arab Emirates situation so far. We cured a lot of cases, and we are in almost a green zone, although our infection rate is a little bit below 1%, perhaps 1 to 2% in some surges. But so far, we're doing very well, and this wouldn't have happened without the appropriate primary care strategic approach and the proper political leadership behind the disease and the pandemic control. And this set the whole country with all partners, strategic partners and stakeholders into action and motion to share the burden of the disease. And this is how we dealt with it at the other end within hospitals and within critical care units in all over the country. And this led to the fact that the testing and contact tracing message that our WHO leaders were advocating for has managed to get the country into the right direction. And I think the country is winning with that. It's a beast, and we have to tackle something that we didn't know about before within our critical care areas. Although sepsis is a known issue in critical care, in all our critical care, we've had a fair knowledge of how to treat it. But when it came with COVID-19, it was a bit of a problem. Some of us were thrown off by how rapid the disease progressed and what we should do with all the data coming from all over the world, specifically China and later on Europe, around certain maneuvering in treating it. So we knew from the start that it's not behaving like SARS or it was not behaving like MERS. And we knew that sepsis as a whole paradigm kills. But if you figure it out early, people who survive might survive more than whoever did not survive. And that was the challenge. As if we were dealing with 2 sepsis or sepsis times 2 or sepsis square. And basically the whole symptoms and signs of COVID-19 mimic sepsis a great deal, especially when patients went into HDU or ICU areas. So, and we know from our surviving sepsis campaigns, we had clear instructions about how to treat sepsis, and I'm not going to go into those in much details, but it's the ABCs of treating sepsis, including fluid management, including lactates use, including immediate and timely antimicrobials use, including the use of steroids, and etc. But when it comes to COVID-19, as we mentioned, the recommendations around COVID-19 started to come through with the beginning of the pandemic, and we collected a lot of data to help us and guide us not to derail, specifically around organ support. For instance, vasoactive management and hemodynamic support was going around adding vasopressors that were evidence-based as per our surviving sepsis campaigns. And that was namely drugs that were available, like the norepinephrine, or to a lesser extent, vasopressins and epinephrine. So we tended to use all those to save lives. And the most important issue that we dealt with in ICUs were the acute respiratory distress syndrome that was either developing so quickly or developing later during the disease, but with so many overlap with different other issues or problems. But we concentrated in the definition coming from the Berlin definition to how to classify the ARDS into the mild, the moderate, and the severe. And within the sepsis or the septic cohort of patients having COVID-19, I think we mainly dealt with moderate and severe ARDS within our critical care areas. And this is, to refresh people, is any PF ratio less than 200 plus any of the radiographic features or the ventilation-related parameters that were deviating from norms, including the compliance readings and the PEEP use. Now, the rate of progression of COVID-19 and sepsis related to COVID-19 within ICU when it affected the lung was just of an acute onset, and the rate was massive and quick. And people swiftly went into a full-blown lung failure within few days, perhaps less than 3 days. And this was characterized more or less by severe shunting and possible small pulmonary emboli compared to the acute respiratory distress syndrome that you used to see without the COVID-19, and hence the difference. Now, other complications were seen in the form of acute kidney injury, and mostly 30% of our cohort in critical care exhibited acute kidney injury, and half of those 30% needed renal replacement therapy, and a third of them needed to have support for liver-related deviation from norm. So 30% had abnormal liver functions. 20%, on the other hand, had myocarditis, and this number was variable, especially around the time when we used hydroxychloroquine and azithromycin, until the evidence came out to suggest that they could be associated with myocarditis. Now, about less than 15% of those patients needed vasoactive treatment at all times, and mostly the vasoactive treatment continued for more than a week in total. Data on the risk of secondary infection, especially pneumonias, were variable, but the majority of those patients had either a superadded bacterial infection or a viral infection concomitant with COVID-19. And septic shock with the multi-organ dysfunction tended to be a sequelae, but it was an uncommon scenario. Now, if we want to concentrate on the lung, because I think COVID-19 and sepsis affected the lungs mostly, we talk about more or less lung compliance that was high, and with barotrauma that affected a cohort of patients that pulled through, and they tended to be less than expected with the severe radiological features. And if I have to gamble and give a number until we get our trials results, I would say less than 20% is the number who exhibited barotrauma. But interestingly, when we compare it to SARS-CoV, we tended to see less pneumothoraces, and the percentage was something like 2%. People from all around the world at the beginning of the pandemic had difficulties into what to start first before we contemplated on intubation. And we had a lot of issues related, intubations and facilities to get those patients to ventilation support. And that's why we advocated for non-invasive maneuvering that could have generated the aerosol and led to a lot of infection control issues, or the use of high-flow nasal cannula. And on balance, the world went into two directions: the high-flow nasal cannula users on non-invasive ventilation, and in general, 50-50 was the answer, and there was no different outcome. But people who tended to use the non-invasive techniques ended up delaying ventilation by about 3 to 5 days. But we learned later on during the wrapping up of the pandemic, and I hope we're wrapping up very soon, that early intubation led to better outcome. And obviously, we tended to have a loss threshold, if we have the facilities to do that, to follow the progression of the disease and to use our parameters, including the severe evolving hypercarbia and the severe hypoxemia associated with hemodynamic instability. And this was generally available in about the third of the population attending ICU. And whether ventilation management made a difference or not, we will yet have to wait and see, but I think it made a huge difference, the way you choose your parameters initially. And the more you become patient with patients, the better the outcome was to be seen. The more you carry on having your low tidal volume ventilation sets, and to avoid the high PEEP ventilations, we saw better outcomes with those type of deals. The interesting thing is COVID-19 has produced huge interest around proning, and proning, out of all the interventions around us, was the cheapest maneuver and was the most evidence-based around us. And in fact, it was an intervention that made the team coalesce around one goal, because to prone a patient, you need at least 5 members of the team. But at the same time, you need 5 personal protective equipments to be available. And that was, again, a challenge. But at the end of the day, it was weighing the benefits and the risks, and it produced huge benefits and huge improvements on patients' oxygenation. Fluid therapy was a bit of a challenge because those patients exhibited GIT symptoms and signs in about 20%, and they tended to present dehydrated with a lot of factors, including fever and diarrhea and a lot. But if we followed our septic guidelines, these people should be on adequate fluid management, but they tended, unfortunately, 30% to be underfilled. And that's what led to the development of renal failure in most of the case scenario. So other options that we used to adopt in treating people with sepsis and respiratory failure in other non-COVID patients or before the COVID era were anything including pulmonary vasodilators, nitric oxide, and so forth. But all of those maneuvers didn't do any good to our patients or didn't produce any mortality benefit. And to be quite honest, the centers I worked in the UAE, we didn't have enough nitric oxide, not because we don't have it, but because we didn't have the time to keep trying and erroring. We used neuromuscular blockade in less than 24 hours if we needed it, but didn't prolong the use for that. And I think we left the ECMO for one center to deal with our patients should we need it, but we didn't use enough ECMO because we didn't need ECMO except in very severe intractable patients. We obviously did not forget the other measures, including proper nutrition, feeding and calories, PPI cover for acidity, skincare, eye care, and all the ancillary measures we do for our regular ICU patients, because this is what matters. And obviously, always remember the carers, the staff who look after those patients, they need to be as good as possible to deliver this, including psychological and mental support. Glucosteroids, until the evidence came from dexamethasone as early as possible in the disease making difference, we have been using it in critical care because ARDS, especially the moderate to severe disease, definitely there was evidence behind it that it improves. And any kind of inflammation and you use corticosteroids for, the outcome tends to be better. So we did not shy away from that, and I'm glad the dexamethasone trial helped us alleviate that, especially in the early COVID patients. Immunosuppression proposed by other scholars, including things like IL-6 inhibitor, tocilizumab, hasn't been used globally. And I'm glad that we didn't, particularly in this side of the world, push for it, because the centers that used it in great details and great affinity ended up having huge amount of fungemias and septic shock that could be resultant from that without mortality benefits. Co-infection within ICU patients tended to be bacterial infections that were the normal hospital-acquired bugs. And in certain studies that looked into a fair number of patients, although bacterial infections were the attributed factors, those studies coming from 3 different parts of the world suggested that viral infections are mostly the dual infections. And for that reason, I think most of us clinicians ended up shedding a lot of antimicrobials over those patients, assuming that this is bacterial superadded infection, and this deviated us from practicing an antimicrobial stewardship programs to the maximum. And I think I'm looking forward to data to tell us about how bad we did and how good we did regarding the MDROs that we have all the reasons and the jobs to stop from developing throughout the next many years in order to stop it from propagating. So in summary, within critical care, sepsis was an issue, but sepsis, when it was added to COVID-19 burden, was 2 issues. But I think the evidence so far is to deliver what is evidence-based, treating sepsis and septic shock with organ failure so far and applied to COVID-19. And we succeeded in most of the case scenarios. And we had to observe those patients and frequently monitor them because the disease was too new to us. We had to look for the risk factor groups, especially the obese and people with abnormal lung functions from before, the hypertensives, and those people just made it difficult to control their ventilation at occasions. But when we went simple and aligned to a very specific protocol, I think the outcome tended to be better. And when we treated the disease as a viral pneumonitis and we followed the proper protocol, again, we tended to win. Proning as a cheap modality was our best thing in hand, the best evidence base that we had in hand, and antimicrobial stewardship application was something that we probably shied away from doing, but I look forward to data to tell us what to do. And I hope not to do in the next pandemic. I hope not to see such a pandemic, but I think within such pandemics, we should have an inbuilt stewardship program so as not to derail from the start. And thank you very much.
Thank you very much, Hala, for that detailed but also quite practical presentation on management of COVID-19 in a critical care setting. In the interest of time, because we are a bit over time, I think we won't take any questions, but I'll urge you to stay till the end of the presentation. And if we do catch up with time, then perhaps we could take a few questions that have been asked through the chat box. So once more, thank you very much.
Cheers. Thank you.
Our next presentation is going to be on COVID-19 therapeutics and what we have learned and where we are going, which is clearly a very topical presentation and also quite controversial, shall I say. And this presentation is going to be given by Marco Cavaleri, who is a pharmacologist. Marco is head of office at the Biological Health Threats and Vaccine Strategy, at the head office of the Biological Health Threats and Vaccine Strategy. He is chair of the European Medicines Agency COVID Task Force and responsible for the European Medicines Agency activities for emergent pathogens, vaccines, and antimicrobial resistance. Marco, over to you. Thank you.
Thank you very much, and hello to all of you. So in my presentation, essentially, I will go through what has been discussed in the context of the WHO Working Group on Therapeutics for COVID-19, and considering my role there as chair of this group. So I will start by highlighting what were identified as the research priority as soon as the pandemic started. So first of all, the importance of identifying candidates for clinical evaluation, in addition to those that were already considered in China right at the beginning of the pandemic for clinical testing. Then, very importantly, setting up a multi-center master protocol to evaluate the efficacy and safety of such agents. And then to have a coordinated collaboration to implement all the different clinical trials that, beside the multi-center master protocol, were going to be set up, and to have a coherent way of looking into all this evidence and try to gather data so that to have a better understanding of what was working and what not. So just to say at the beginning, of course, there were a few options to look at, in particular repurposed agents or agents that were already under investigation or have been studied in preclinical models for other coronaviruses, in particular MERS and SARS. And among these, the two compounds that were identified at the beginning were the two antivirals, remdesivir and lopinavir-ritonavir combination, which is a drug already approved for the treatment of HIV, but for which we had interesting data in animal models for MERS in particular, and the combination with interferon beta was undergoing clinical trials in Saudi Arabia for MERS. So definitely these were the two agents identified at the beginning, but other options were considered, including different immunotherapies and the use of convalescent sera that at that point in time was not really on the table as a real option, but as we all have seen recently, has emerged as an important intervention to be further studied in clinical trials. So at that time was also identified in the context of the research agenda which were the areas that were considered important in order to move on with the evaluation of agents for the treatment of COVID-19. And among these, a repository list of laboratories was considered important. That has been achieved to a large extent. And also, very importantly, the setup of animal models for both mild disease, but also for more severe disease. And while we ended up having some models that could be deemed appropriate to investigate therapeutics for mild disease, we don't really have established models for severe disease. And that is something that we need to work on more in the near future. Also importantly, the standardization of the protocols for viral propagation was identified as an important area, and also the importance of having data not just in viral cell or with certain cutoff for activity, but also data including primary airway epithelial cells were deemed important. This is and also these would allow the interpretation of the results across different laboratories and are considered essential for the screening and selection of candidates for future clinical trials. And of course, we see that there is more work to be done. Indeed, I have to say it's been a bit disappointing to see that a compound like hydroxychloroquine was tested in primary airway epithelial cell only several months into the pandemic and after the large clinical trials had already delivered important data on the role of this agent. So if this data were available earlier, probably history would have been different. Then another important area was immediately identified was to the setup of clinical trials for pre-exposure prophylaxis or post-exposure prophylaxis, acknowledging that for vaccines it would have been a bit of a longer journey before anything would have been ready for large clinical trials. So try to understand if there are any compounds that could have or could play such role and therefore being properly studied in clinical trials. And for this, there have been considering that a number of studies were already initiated or starting rapidly, it was felt important to bring together all the investigators and discuss together how to share data. And in this sense, a core data monitoring committee has been established that could serve as a tool for sharing information between the different DMCs for the various trials. So an important role that has been appreciated by the scientific community and now is active. And of course, important also to think about setting up further master protocol for this kind of testing of future COVID-19 drugs. Also, not to forget the role of having adequate supply of therapeutics, so having a good overview of what is the availability and the production capacity of the promising candidates, and for this, the global collaboration to accelerate the development, production, and equitable access of new COVID-19 diagnostic and therapeutic vaccine is in process at WHO, together also with the COVAX initiative that allows really a good dialogue also with the developers in order to be sure that we don't have shortages and there is fair and equitable access to any of these new drugs that is emerging. Now, a very important point and an important remark from my side is that we noticed right from the start the huge amount of fragmentation in terms of clinical trials, with a lot of small trials, being starting all over the world. But clearly, the majority of these trials not being able to generate sufficient evidence on safety and efficacy. So the big plea has been to try to merge all these efforts into large clinical trials across different countries, across different investigators, so that we can get mature data on all these treatments. And we really hope that from now on, this process will continue with more aggregation and the ability of conducting large clinical trials that will be more informative. And indeed, one of the areas said was the setup of a master protocol. This has been done with the Solidarity trial, which has been working as an important anchor at the international level for bringing together investigators and working together in order to generate important data that would inform regulators and public health using all-cause mortality as primary outcome. So this is a very important exercise that is continuing as we speak. And then also trying to bring together all the emerging data from all these different randomized controlled trials in order to appraise them and synthesize what is the outcome and what can we learn from all these studies together in order to inform clinical practice. And as mentioned, indeed, the steroid meta-analysis just recently published is a good example of the relevance of doing these activities when it's done in a rigorous way and based on good clinical trials to start with. Another point that was discussed from the beginning was the role of combination therapy. Now, this is an area that has been moving a bit slowly, but still there has been some progress. And now the point will be to see after the initial outcome from the trials using monotherapy, either as antivirals or as immunomodulator, to see really how we can combine all these different drugs and therapeutic modality into combination therapy, either in parallel or in sequence, that could really increase survival and cure rate for COVID-19 patients that are hospitalized. So to summarize, the preclinical aspects are extremely important, and these cover both the relevance of having good in vitro assay, particularly for putative antivirals, which should not be just viral cell, but which should be broader, including primary human airway cells. We need suitable animal models in order to understand really how to move on with the different therapeutics, and particularly in the context of severe and critical ARDS and hyperinflammation, as sometimes we are really struggling to see how to move on therapeutics with immunomodulatory activity for which we don't know much. The role of new drugs for the prevention and post-exposure prophylaxis is also an important area not to be forgotten, and we look forward to see what could be the next generation of agents, other chemicals or monoclonals that could be used in this sense. And also good tools to have a rapid understanding of the value as proof of concept of any of these new agents before embarking into large phase 3 trials. And also, last but not least, what we have been learning is that we may have to tailor a specific drug for a specific phenotype of the patient. And so we will need to have clinical trials that will be informative on what is the efficacy and safety of different therapeutic agents, but also having a better understanding where they could have a major impact in terms of the course of the disease, and in which type of patients would be worth investigating, because we think that only there probably there could be a significant effect. So this is more work to be done, and is part probably of the next generation trials. All these elements will have to be incorporated, and we look forward seeing indeed what the new agents that are emerging could show in large clinical trials, that again, they have to be large enough and well constructed in order to provide us with the information that we all need for regulatory purposes and for informing public health. So I thank you very much on behalf of the entirety of the therapeutic working group. Thank you.
Thank you very much, Marco, for that really interesting and thought-provoking presentation on COVID-19 therapeutics, current and also future research. It's really interesting. We have time for a couple of questions, if you don't mind, Marco. And the first is a question about the, what I would say, controversy with sort of mixed results for some of the trials and observational studies so far, for example, with hydroxychloroquine. And would appreciate your thoughts as a question that's come up in terms of what should be believed with the controversies around results with hydroxychloroquine trials and observational studies, and secondly, whether there is any role you think for hydroxychloroquine in early disease, because the trials may have been use hydroxychloroquine mainly for moderate or severe disease.
No, thanks for the question. Indeed, we are all looking into the role of observational studies in informing clinical practice and decision on which therapeutics might be effective in treatment of a number of diseases, and for COVID-19 as well. The problem that really emerged here is that we need to be sure about the data source, about the quality of the data that underpins the evaluation from these observational studies. And of course, not forgetting that unavoidably observational studies are more prone to biases than randomized controlled trial. So regretfully, we have to be reminded here of the importance of conducting rigorous research, also when it comes to observational studies, if we want these studies to be believed as important and informative. I think that still they play a role and we should continue to use them. But what is emerging here with COVID-19 is that definitely to have a good understanding of the activities of therapeutics, we need randomized controlled trials. This is the only way of having some definitive answer on the efficacy of these agents. And hydroxychloroquine indeed is a good demonstration that the large trials of Solidarity and Recovery have been able to show that indeed these agents are not providing a benefit in terms of mortality for hospitalized patients. Now, coming to your point of whether they could have a value in earlier treatment, I have to say that, of course, only clinical trials can tell us at the end of the day. However, I'm quite concerned about all the emerging preclinical data, both from animal models and from these in vitro studies using lung epithelial cells, in which they show that hydroxychloroquine is not really active as an antiviral. So I think this poses a number of questions on whether it would be worth to progress study on hydroxychloroquine in light of this evidence.
Thank you very much, Marco, for that enlightening response. And in the interest of time, I think we'll also move to the next speaker. So thank you very much.
Thank you to you.
So our next presentation is going to be about mobile emergency care units and Ebola sepsis, how that improves Ebola sepsis survival. And the presentation is going to be given by Richard Kojan. And Richard is a clinician, physician who has been engaged in low and middle income regions for more than 15 years, mainly practicing emergency medicine, intensive care, and also polyvalent critical care. He has been involved in developing and using the portable biosecurity emergency care unit, which is acronym CUBE, has been used to optimize the care for patients with Ebola viral disease. Richard is a specialist physician in ICU and in anesthesiology, currently working in collaboration with different teaching hospitals and multiple partners with international research societies across Africa, Europe, and North America. The floor is over to you, Richard. Thank you.
Thank you. We are to share our experience from the portable biosecurity care unit, as CUBE, as we call CUBE in French. So, and also the sepsis care in Ebola context. So, from the introduction, I will say that we know that the Ebola virus disease was first discovered more than 40 years ago, following the first outbreak in DRC and in Sudan. So we know also that the patients who often bring back the Ebola virus disease from the countries with low resource to the high-income countries have always received optimal standard care. So the lab for good diagnosis and for monitoring for all metabolic disorders. Then, in addition, experimental drugs have always been available in compliance with the standard of care in each country. So from those rich countries, the septic patient always received the best supportive care. But in contrast, we know that the Ebola virus disease patients from the low-income setting have been provided with minimal care services during many outbreaks. So the objective was to protect health workers and health facilities from the contamination. And we think that this is one of the reasons for high mortality of Ebola virus disease in Africa, particularly for sepsis case under Ebola context. To address this gap in supportive care for Ebola virus disease patients, we developed the portable biosecure care unit as Cube. So the Cube is the transparent room, the single transparent room, which one offer 9 meters square for the patient and for the health workers inside the Cube. So inside the Cube, we have a control on temperature and the pressure. And with the Cube, we can, the intensive care and the critical care become possible in the most remote village. So what's the benefit with the Cube? With the Cube, the monitoring become permanent and the global one. So monitoring, clinical monitoring, and the lab monitoring become possible with the point of care as biochemistry, biology, hematology. So also we introduce the hemoculture technique in our context. Talking about hemoculture technique, let me say that this was possible in partnership with IMT, which one is Institut Medical Tropical from Belgium, and also in partnership with INRB, which one is Institute National for Research Biology from Kinshasa in DRC. So we did it at the end of the last outbreak in East DRC. The second one is that in this context, with Cube, it was possible for us to introduce the ultrasound for hemodynamic monitoring, and the lungs, heart, and kidney monitoring become possible with this approach. And the third one, it become possible for us to individualize the critical care in our context for the patient, for the Ebola patient, in a context with low resource. So from our last experience in West Africa, also in Ebola context, this approach with the Cube changed completely our life, I can say, for us as health workers. But this is change also life for the patient. So the patient now with this approach can stay in a real hospital environment, close with his family and close with the health workers permanently. So with this approach, it become possible for us to implement, and we implemented the optimized clinic care protocol for Ebola virus disease, which one was validated by the national authorities in DRC. So the mental care also become possible with this approach. And as we can see from the study, RCT study, which one was a drug study, clinical study in Ebola context, show that demonstrate a significantly reduction of mortality for those patients who consulted early. And the technique for hemoculture, as I say, become possible in this context, and we did it in partnership, as I say, with different partners. And this is, I want just to show some device when we introduce in this context for good monitoring for the patient and the supportive care. And for short observation from our experience regarding 120 patients who died in our context, for the patient to stay longer in hospitalization, what we saw that it was that from their admission, they came with a high number of leukocyte cells. If we can see well in hematology, high number of leukocyte cells, and also with high temperature and other disturbance regarding the biochemistry parameter as a CRP. So when we start the supportive care, the number of leukocyte cells decrease for those patients who stay longer before death, and their temperature decrease also, and the CRP also decrease, and all mediator inflammation decrease. But 1 week after, 8 days, what we saw is that the leukocyte cell number of leukocyte cells start again to increase in the same way with CRP, and temperature also increase, and lactate also increase, and the pH decrease. So this patient, after more than 10 days, they died because of septic shock and multiple organ failure. So this is for the patient who stay longer before the day. But there was other category of patient, or the group of patients who stay not long time in our hospitalization, but they stay within 4-8 hours. Those patients, the probable cause for this patient death was the delay of the perfusion, liquid and electrolyte perfusion. But nevertheless, in both of different group patients, there are various other aspects that still need to be analyzed: the whole virological and immunological dynamics, and also the use of experimental drugs. This is just to share with you that some point of care we introduce in approach with Cube regarding for good monitoring for biochemistry, hematology, and the gas for the patient. This one just to show that the hematology at the admission for the patient, the number of leukocytes was high and then decreased progressively for those patients who died, who stay longer in our hospitalization before died. So this data is just only for the patient who died. So we want to focus specifically on some parameter from their hematology. So from this observation lead us to individualize the critical care for the patient in our context, for example, by anticipating the administration for the vasopressor drug administration for those patients, septic patients. So also this observation lead us, as I told, to introduce the technical culture for specific antibiotic in our context. And I can say that for the future, the PCT, procalcitonin, PCT, should be done systematically in Ebola context. This is possible now safely and with the approach by Cube. So we hope that in the future, more objective data will help to implement appropriate protocol for anti-effective management of Ebola virus disease patient. So before I finish, I want just to share with you this illustration for this complex case, for which one was a patient 30-year-old man confirmed Ebola virus disease, which one was admitted in May last year, and this patient died after 18 days in hospitalization in our cube. So as you can see, from their admission, this patient had a high temperature and high CRP and high viremia. So when we start with supportive care and good monitoring, what we can see, so the temperature decrease and the CRP decrease and all mediator inflammatory decrease and also the viremia decrease. So, but 10 days after, as you can see in the graph, the temperature start to increase again. Despite supportive care, the temperature increase again the same way with the number of leukocyte cell and the CRP and also the lactate also increase. And this patient died 18 days after admission in sepsis shock with multiple organ failure. Thank you.
Thank you very much, Richard, for that really excellent and inspiring presentation. You've shown how an innovation can have an impact on early monitoring, early diagnosis of deterioration in patients with Ebola viral disease, and how that can also have an impact on how supportive care can also have an impact on mortality. All things which are very relevant for Ebola viral disease and also sepsis. You also highlighted the difference in mortality in the Western world, where patients have been diagnosed with Ebola viral disease, and also in parts of Africa, where we've had outbreaks of Ebola viral disease. And a question I would wonder is, do you have any data so far to suggest that the Portable Biosecurity Emergency Care Unit, the CUBE, has had an impact on mortality, and also what is the impact also on health-seeking behaviors for the population when if they've seen that being now able to maybe access good quality care?
So at this time it's a little bit complicated. It's not. I can say it's a little bit complicated to say just only the cube, to introducing the cube and it's improve mortality. So at this time, it's complicated to demonstrate, because in this context, we introduce many things in the same time, not only the cube, but we use also drugs, experimental drugs. So we ameliorate supportive care. So there is many factors there is many aspects can in the same time, those different factors can explain that why the mortality decrease, you know, for when if we see well regarding the study we did in this context. So there are many factors, not only the cube, but also the drugs, the supportive care. This is the reason can explain why the number of mortality decrease. But I think that introducing the cube in this context in a country with low resources, this has changed completely our approach. This has changed the life for the patient. This has changed the life for our as health workers, because you know one of the complications from Ebola disease is the shocks. So without the cube, it's complicated to have good monitoring, permanent one monitoring for the patient. It's very complicated without the cube, because it will not be possible to stay close with the patient to maintain a good monitoring. So it's very necessary for us. I think the cube is very, very important to ameliorate, continue to ameliorate care for the patient, not only for Ebola disease, but for different other patients who need intensive care or critical care.
Thank you, Richard. It clearly gives hope for healthcare workers to be able to look after the patient safely, and also for the population who can access care, good quality care with this innovation. What about the cost and the scalability of the cube?
So the cost of the cube, it's one cube, the cube with all device. So it's $16,000.
Excellent. Thank you very much, Richard. And I think if we have some time at the end as well, we may take some other questions. Clearly, really useful presentation, and thank you for that. So we're going to move on to the next presentation, and it's on the inflammatory response due to COVID-19 infection. And our presenter, last but certainly not the least, is Yi-Sin Liu. And Yi-Sin is the Executive Director of the National Center for Infectious Diseases in Singapore. As an adult infectious disease specialist, Yi-Sin has led her team through multiple outbreaks in Singapore, which include the Nipah virus, SARS, Zika virus, and multiple surges of dengue fever, as well as monkeypox in May 2019. So clearly somebody who has been involved in a lot of emerging infections, and we look forward to her presentation. The floor is yours, Yi-Sin.
And thank you for giving me this opportunity to be with you this evening. Let me just quickly introduce where I am right now. So you can see Singapore is a dot in Southeast Asia. And what we have done in the recent years is to establish the National Center for Infectious Disease, a central piece in Singapore to be able to manage outbreak. Next. Now, coming back to COVID-19, I'm sure all of us would know that China made the first discovery as well as report on COVID-19. And this is what from the researchers from China putting together all the informations and then ask the questions that the clinical presentations of COVID-19 in fact fit very nicely into virus sepsis. And what they have described so far is patients presenting with shock, cold extremities, with multiple organ involvement. And that puts together the information as the proposal that this indeed is a viral illness that leads to sepsis. And further on, describe the situations to put together the concept. So first of all is the clinical manifestations that fit very nicely into the concept of sepsis with multi-organ failure. And then describe pro-inflammatory cytokine response, showing you the elevations of pro-inflammatory cytokine. And in addition to that, there's a significant depressions in the lymphocyte with significant lymphopenia, with peripheral drops in terms of the CD4 and CD8 count. And the author then subsequently asked these questions in the clinical phenomena and as well as histological phenomena, whether there is an effect of direct viral invasions, or is a systematic cytokine reactions, or indeed it could be a presentations of both. And I think most people by now very familiar, in fact, what sepsis means. A lot of exuberant inflammatory reactions, the dysregulations of the immune functions that subsequently lead to multi-organ failure. And let's have a quick look in terms of how the immune system functions in the human body. We have immediately, there's an innate immunity followed by adaptive immunity. The innate immunities will kickstart the defense against the virus almost immediately when it comes into contact with the invading pathogens. And the entire immune system is orchestrated in the way to protect the human from the pathogens. And the whole systems of reactions usually is orchestrated and is a balance of the system in terms of pro-inflammations as well as the regulations so that we can return to normal as quickly as possible. However, in COVID, today we know the entire clinical spectrum of clinical illness, from asymptomatic cases to very mild disease to the next spectrum of very severe clinical manifestations. So in certain individuals where the virus can be well controlled right at the beginning of the clinical illness, they recover from COVID-19. However, in small subset of individuals, because of the exuberant immune response that leading to productions of cytokines and subsequently of what is being coined as cytokine storm, and further damage the organ, and for the small minority of individuals that then succumb to the infection. And this is to show you the spectrum of the extreme where patients succumb to the severe disease. So from the histology, you can see these significant destructions of the pulmonary, of the alveoli, as well as the formations of the hyaline membrane in the post-mortem finding that we can see from here. And in addition to that, a closer look in terms of the infiltrating cells. So from here, you can see that there are a lot of the lymphocytes being infiltrated and being destroyed lung tissues. And this is a further look in terms of using electron microscopy, looking at the invasions of the virus itself. So this is looking at the respiratory system, from the upper respiratory systems down to the lung tissues, the alveoli, clearly showing you the viron is present in the upper respiratory tract, as well as presence in the lung tissues, as well as that presence in the macrophages in the lung. So here, many of the postmortems shows significant tissue damage with a lot of infiltrations of the reactive cells, as well as direct invasions of the virus into the lung tissue. And I think most of you will be quite familiar here that not only the lung tissues, that is, we can see the viron as well as inflammatory response. Here you can look at the endothelial tissue as well, showing you direct viral invasions. You see the virus particles in the endothelium, as well as lots of infiltration cells around the injured tissue. And not only that, this hypercoagulable states is something that we are seeing a lot of reports of patients that do badly with COVID-19. And this is one of the features that you see with the very gross formations of the clot showing pulmonary embolism. Now, this is a very nice article that actually put together the concept of the hyperimmune reactions to the invasions of the virus. And here the authors present this idea of direct invasions of the virus as the virus factors, leading to pro-inflammatory reactions, as well as a renin-angiotensin axis response and hypercoagulable states. Now, what is important here is that all this vicious cycle that is introduced by the virus, in fact, are all in play all at the same time. Now, coming back to the virus itself looks for ACE2 receptors to gain attachment and again into the human tissues. Here you can see that the virus, in fact, possesses a very unique features where it interferes with the attachment, interfere with the productions of the pro-inflammatory response. It interfere with interferon with the inability for the human host to be able to overcome the virus, leading to virus replications in the upper tract when the virus enter into the human body. And at this point in time, it actually explained as to the reason why there is high level of viral replications at the early phase of clinical illness and leading to the high speed of transmissions of the virus among the human. Now, and because of the inability to control viral replications, there is a migrations and invasions of the virus into the lower pulmonary tract. And again, the virus interfere with the immune response with an exuberance productions of the cytokine. And this is a classical example of the higher productions of interleukin-6, with alpha TNF that giving rise to the entire cytokine storm that the patient experienced. And here you can see that we put together the diagram showing you the exuberance productions of cytokine, and that leads to multiple organ involvement in that hyperinflammatory states of the COVID-19. And here the authors then present the idea of renin-angiotensin's vicious cycle with the depletions of ACE receptor. In fact, it enhances the secretions of TNF alpha and therefore bring in even more cytokines. And because of the depletions of ACE2, there is this vasoconstrictions effect, leading to more tissue damage, leading to more tissue fibrosis. And this is another vicious cycles that we see in the patients that being induced by COVID-19 or SARS-CoV-2 virus. And to the hypercoagulable states, I think today most of you would understand that D-dimer is one of the features that closely associated with hypercoagulable states, together with elevations of the inflammatory markers. With all this understanding, let me introduce to you the local research in my center. We established a longitudinal cohort under the PROTECT study. And this is the core that we support multiple activities that include studying transmissions, using the cohort to understand the clinical trials study, the diagnostic capability, as well as the important thing is to understand the pathogenesis. And of today, we have recruited more than 600 individuals, well-characterized clinical characters into the PROTECT study. In the interest of time, I will quickly show you some of the key findings that we have. So what we had done is to look at different patients' severity, different clinical phenotypes, comparing patients without pneumonia, patients with pneumonia, and hypoxemia. And from here, you can clearly see the difference in terms of the inflammatory response in this particular group of individuals. You can see the elevations of C-reactive protein, elevations of IL-6. However, the total white remains relatively stable across the three different groups of patients. If you were to look across the right-hand side, looking at the group of patients with pneumonia and hypoxemia, in fact, you see more of the positive significant factors, more than patients that just with COVID pneumonia without hypoxemia. This is a longitudinal cohort. What we have done in the top panel here that you can see is to look at the longitudinal tracking of the inflammatory markers as well as the lung damage markers. But the more important thing is to look at the middle portions. You can see that when we compare healthy individuals with patients that with mild clinical illness, patients with pneumonia without hypoxemia, and the extreme right box, you see patients with pneumonia and hypoxemia. So the heat map shows you the difference in terms of the cytokine response. And here we clearly demonstrate to you that the patients with pneumonia and hypoxemia has much, much higher elevations of inflammatory and cytokine markers. And we attempt to look into the relationship of the different markers. And this is one of the study that we did, trying to examine whether IL-6 could be one of the key target that we can use in terms of clinical therapeutics, whether or not anti-IL-6 would be one of the good therapeutic arms that we can experiment on. Then we went on to do further study, looking at the particular peripheral white cell in the same group of cohorts. We looked at patients with normal, healthy individuals, compared with patients with pneumonia, as compared to patients with pneumonia that without hypoxemia, and patients with pneumonia with hypoxemia, and into two groups, those that without needing to go to ICU and a group that needs to go to ICU. But important thing here I want to show you is basically on the top row and bottom row to show you the difference in terms of the immature leukocyte that we found in our populations. So although the peripheral total whites number remain relatively stable, but when we break down into different cell types, we realize that the immature neutrophil in fact outnumber and became a significant marker to differentiate patients with more severe disease compared to patients with milder clinical illness. And for situations with IL-6 and some of the cytokine that is difficult or not available for testing, perhaps looking at immature neutrophil could be a relatively good markers to focus on. And if we just concentrate on the right bottom angle, showing you the comparisons of using IL-6 as well as IL-10 in correlations to the immature lymphocytes, you can see a very nice correlations. The higher the level of IL-6 than IL-10, is highly correlated with a higher number of immature lymphocytes. This likely represents the kind of myeloid response where there is immature lymphocytes in circulations and there is possible migrations of the lymphocyte into the lung damaged tissue. Now, how do we bring back all these informations into clinical management? So here you can see that in clinical manifestations, we have two groups that we pay specific attention to, patient with pneumonia and patient with pneumonia with hypoxemia. So from our studies, we've clearly been able to demonstrate that patients with pneumonia and hypoxemia has a very different cytokine profile compared to patients with pneumonia without hypoxemia. So it's likely that this explains the current finding as to the use of anti-inflammations such as steroid that is useful and with more clinical benefit if you were to use it in a more severe clinical illness, those patients with hypoxemia. And possibly this is a sweet spot that we have to look at as to when to be able to start anti-inflammatory agent in order to stop and arrest the cytokine storm in patients with pneumonia and hypoxemia. I think this is my last slide. I think without the entire teams behind me, none of all this research and clinical management can happen. On behalf of the entire team, I would like to thank WHO for giving me this opportunity to present our work and also to look into the issues of inflammations in COVID-19. Thank you.
Thank you very much, Yi-Sin, for that really useful, interesting presentation demonstrating how COVID-19 can cause viral sepsis. Just one question, if you don't mind. There've been a number of questions about how you can differentiate in a patient with COVID-19 sepsis caused by the virus and sepsis caused by bacterial superinfection. I wonder whether you had any thoughts about that and potentially maybe comment on the role of biomarkers such as procalcitonin.
Yeah, thank you. So in our cohort that we put together, most of the patients, in fact, the ICU number is not fantastically big, and antibiotics by then would not be a big factors in terms of the bacteria treatment. So we do have very nice clinical cohort where we can clearly classify them as a viral pneumonia rather than superimposed bacterial pneumonia. And with that group, we have clearly demonstrated the cytokine productions, the differentiations, and I think we could demonstrate quite well in terms of the viral effect in causing the cytokine reactions.
Excellent. Thank you very much, Yi-Sin, for that great presentation and also for taking that question and a very clear answer. I would just like to ask Dr. Hala, who is still on and didn't have a chance to take a question, but if I think she's still on, to take this question, which is about, and is linked to the question I've just asked Yi-Sin, and that in your experience during the COVID-19 surge in Abu Dhabi, UAE, how do you think we can maintain antimicrobial stewardship, and what was the potential impact of antimicrobial use on antimicrobial resistance where you worked?
Thank you, Emmanuel, for this very important question. And the short answer to that is we don't know. But I think if we stick to basics, I think we could find our way. Now, basically, I think globally or within our cohort of patients that we dealt with in critical care areas, we did not have enough time or the expertise to really guard our antimicrobial stewardship programs, because patients, when they hit the ICU units, we started looking for a war zone kind of treatment. We wanted the intensivists to guide the way and to have everybody who's collaborating in the treatment to try and help out, since it was very, very overwhelming. But having said that, when we had protocolized approaches in some hospitals, the outcome was better. Protocolized approaches and dedicated microbiologists at the end of the line helping out, this definitely reduced the abuse of antimicrobials, especially at the first instant when patients presented with the similar symptoms and signs. Now, the impact that I've seen vividly was actually the surge of MDROs and candidemia. We had some Candida auris cases in certain pockets of critical care units. And when we link that to patients and use of antimicrobials, we found that by and large, the prolonged use of devices like central lines and the prolonged use of steroids was probably a risk factor for those patients. The MDROs, from the bacteriology point of view, were mainly the carbapenem resistant organisms, but they tended to be uncommon, but they were available. So if I have to give a number, it was definitely less than 5% of the cohort within critical care. And again, we went again and revised our strategies, and we went again and reset things. Things started to improve. We saw in a small category of patients some Acinetobacter baumannii affecting those patients as well. And this brought a lot of challenges regarding dual treatment versus one treatment strategy, colistin or tegacycline colistin combination, especially amid renal failure in those patients. So I think we saw it in scattered proportions. It was not very uncommon, but it was common. And I think our practices had something to do with it. And if we want to prevent it, we have to really go back to basics, revise, review, and have our multidisciplinary teams being there within the pandemic. And the pandemic has its challenges, but I think once we had that focus, I think we got it right, but that was towards the end. Thank you.
Yeah, so I would just add on in terms of what Ted mentions about multidisciplinary approach. I think those are extremely important, because COVID-19 not only affecting the lung, but many other organs as well. So we do bring in a multidisciplinary team into the ICU setting to take care of patients. And infectious disease clinicians are always there, and antimicrobial stewardships is always present because of the infectious disease physicians as one of the active partner in taking care of patients. So currently we are now looking into our own data and asking the questions of antibiotic use during the epidemic, during the high period of the COVID cases in Singapore, as well as not forgetting non-COVID cases, regular cases, whether or not there's any change in the antibiotic practicing behavior. So hopefully, this study will be able to give us a bit more insight in terms of how we manage antibiotic against new invading pathogens as well as regular routine use.
Excellent. Thank you really for that. Those excellent answers. So I think we're coming to the end of the fourth session on sepsis, Ebola, COVID-19, the fourth session of the World Sepsis Congress Spotlight 2020. Just a few closing remarks. The first is to say that the sessions have all been recorded, and we would urge you to visit the website, our website, which is www.wscspotlight.org. Please do visit the website and then sign the World Sepsis Declaration. advocacy for sepsis improvement is key objective of the Global Sepsis Alliance. So we urge you to really support the Global Sepsis Alliance and the WHO in organizing this event by signing the World Sepsis Declaration. And please also follow the World Sepsis Congress Spotlight on Facebook, Twitter, and Instagram, and share. And the sessions have been recorded, and they will be put onto YouTube and also put onto Apple Podcasts as a podcast starting from the 15th of September. So from the 15th of September, every week, there will be one session of this Congress that will be released on YouTube and also Apple Podcasts, which you can access starting the 15th of September. And also I'd like to finish by thanking the WHO, Global Sepsis Alliance, and most importantly, all our speakers for today that have done a brilliant job of presenting on this very important topic. And I'm sure if we were face-to-face in a conference room, you would hear a loud cheer and claps in the background. Once more, thank you. Thank you to all the speakers, and have a nice rest of the day, morning, or good night. Bye-bye.